Hello, everyone. My name is Michael Homer, and I'm one of the doctors at Reproductive Science Center in the Bay Area, coming at you from San Jose right now. And I'm really glad that you joined and to hear me talk. And today I want to talk to you about PCOS and fertility, and what I've titled Things to Expect for When You Want to Be Expecting. I think that I've been dealing and helping women with PCOS for almost about 10 years now. And I think that PCOS is such an important topic for a number of reasons. The first thing is that it is not uncommon. It affects somewhere between 5 to 12% of any given country's population. And I also think that PCOS is tough, right? Because it affects things that people find important: hormones, health, weight, appearance, and fertility. And because it is so variable in its effects, and the symptoms overlap so many other diseases, it's also really confusing. And maybe it doesn't quite get its due when you go visit a doctor's office or maybe read online. People maybe focus on some other types of diseases or issues or syndromes, but PCOS is prevalent and it's important. So I'm really glad you joined me today. So I always feel that one of the most important messages that I can give any woman who suffers from PCOS is that I understand that it can be overwhelming. It's tough. When dealing with fertility, however, it is one of the more straightforward issues to deal with. For most women that come into my office, if they have PCOS, I kind of sit back and I know that it's a little bit of a hidden superpower, right? It may have been the reason why you came to see me in the first place. And so in that sense, it's absolutely a hurdle or an obstacle or something else to overcome. But the key about hurdles is that you can get over them. It might take some climbing, you might need some help, or maybe you can jump over right away, like really fast, right? But it's something that you can conquer and get to where you want to be. I think that it is also something where in my office, it's almost exciting. Like someone comes in and they have polycystic ovary syndrome, and it's like, okay, like cool. Like I have lots of eggs. And that's really cool. That's a really good thing to walk into a fertility clinic. Have you seen someone like me? If I see PCOS on the diagnosis or come to that conclusion, of my own, with the patient, then it's like, okay, great, we got stuff to work with. Like this can be this, we can do this. Okay. So whenever you start, it's like almost like a law. Whenever you start with with PCOS, you guys talk about the definition, but also because it overlaps so many things. Maybe you're watching this and you've been diagnosed with PCOS. Maybe you were just like, well, I think I have it, or oh, I was told when I was 15 that I have it because my periods weren't regular. So let's just make sure that at least you've heard this once, right? First of all, PCOS, polycystic ovary syndrome, not the best name. Okay, polycystic cyst, we think that's bad, right? So a cyst is technically any fluid-filled sac, but that includes a follicle. So really, Stein Leventhal, with the doctors or physicians who help sort of coin it and describe it and talk about it, they went with polycystic ovary because that kind of fit the medical jargon at the time. But you should just know that those aren't cysts; those are follicles, right? Those are lots of eggs, so it's okay. But a syndrome is a group of symptoms which consistently occur together, okay? So there's no specific tests. Like we think of like a genetic disease or an autoimmune disease, like looking for the antibodies or a specific, mutation on a chromosome. PCOS doesn't work that way. So there are three different markers or clinical syndromes or laboratory syndromes that one has to have in order to have diagnosis of PCOS. And most definitions at this point will say 2 out of the 3 is going to be fine. Fine as in it's going to diagnose you with PCOS. So the first is clinical or laboratory evidence of hyperandrogenism. So when we talk about hyper is high, androgen is essentially the most important one. There is testosterone in this setting for PCOS. So laboratory hyperandrogenism means that there's a blood test, and the blood test shows the testosterone level is high. Now, just to give you a sense of scale, men somewhere like 300 to 500, on that scale. If a woman is high testosterone, it means she's over 55. So it's not that hyperandrogenism with PCOS has testosterone like male patients, but it's just higher for the bell curve basically. Or so the laboratory or clinical evidence. Clinical evidence of hyperandrogenism essentially is hirsutism. Hirsutism is unwanted hair growth. And this is not like the arms or the legs hair. Okay, that's from mom and dad or grandma and grandpa. Um, it's familial, okay, or hereditary. But centrally grown hair, so upper lip and chin are the most common, middle of the breast, excessive pubic hair, hair in the back, okay, those are and not the vellum hairs, the small little hairs that maybe you think of elementary school children might have, that kind of thin wispy white. That's not what we're talking about. We're talking about terminal hairs, like dark, coarse, thick ones. Okay, doesn't have to be a lot. Hopefully it's not a lot. But having even a couple of those that are unwanted in there, that is a small clinical sign of hyperandrogenism. So either one, either the laboratory or the clinical signs with the hair. The second one is ultrasound. And so with the ultrasound done transvaginally, because the ovaries sit right there, it's the best view that you can get. You look. Remember we say those polycystic. It's not cysts; those are follicles. But essentially, a woman has a pool of follicles at all times. It's always ready to be ovulated. And even if you don't ovulate regularly, like women with PCOS have, that pool is still there and constantly gets refreshed all the time. But that sitting number of follicles, that's what we're looking for. So if we see more than 20 follicles per side, then that's considered kind of a check on that ultrasound marker. Okay, so hyperandrogenism, which is the testosterone or the hair growth. We have the ultrasound as the second part. And then the last part is the one that probably everyone is a bit more aware of, is that irregular menses. Okay. So, and I'm not talking about, it's 28 days, then it's 27 days, then it's 30 days. This is menses where they are regularly irregular. So that cycle day 1 is the first day of a full bleed. If that from that cycle day 1 to the following cycle day 1 is less than 21 days, or if it's, which is the more common one, if it's greater than 35 days, that's the most common one. That's considered outside of the bell curve. And so those three markers, ultrasound, looking for the follicles, polycystic ovaries, looking for high testosterone or hair growth, okay, or irregular periods, 2 out of the 3, and we're working with the clinical diagnosis of polycystic ovary syndrome, except for it needs to have some other blood tests drawn with the testosterone to make sure it's not something else to do with the adrenal glands, the thyroid, prolactin, a bunch of other hormones. Okay, so PCOS is a diagnosis of exclusion, so never forget that. Sometimes people might have the diagnosis from the doctor, like, oh, you have regular periods and maybe your BMI is above 25. It's probably PCOS. You never know until you see a doctor and they rule out all the other things that possibly could be. Okay, so keep that in mind. But what doesn't define PCOS, but may in the future, there's some blood testing, AMH, anti-Müllerian hormone. I won't go into too much detail about that, but that's sometimes you might have heard about. I just wanted to address it. Not quite yet ready to call it for a diagnosis, but it may be in the future. Other things that are associated with PCOS is like acne or some other blood tests that may be high, like LH. Those are associated with, but technically not diagnostic of. Okay, so you make an appointment with your doctor, right? Let's go. So now we have the diagnosis or definition down, right? So your journey, right? When you want to be expecting. So maybe you make an appointment with your doctor, right? Perhaps an OBGYN or a friendly REI, reproductive endocrinologist, and infertility. That's the specialty that I am, but not REI, not like the camping store, because that's more fun. That's definitely more fun than at my office. But we get things done too. So I'll get into specifics of the treatment in a bit. But right now I want to focus on what things that you can do to optimize yourself. Okay, and I used to be an engineer, mechanical engineer, and I think that word of caution here, when a lot of women come to me and say they want to balance their hormones, or they feel like their hormones are out of balance, and I totally get that point of view. It makes sense. I mean, like I just told you, testosterone levels can be too high. Maybe that's throwing other things off. But I do, maybe it's semantics, but I do feel overall that maybe thinking about that way might be harder, because balance implies that you're constantly, it's life, right? You're balancing maybe home and work and social and friends and family and whatever. And keeping that work-life balance, right? That's really hard to do, but it seems like you're constantly trying to make these adjustments, right? But I feel like a better word to describe it is that, you're going to take polycystic ovary and things that come with it. You're going to, what I want to do is address them discreetly, like in each individual one, right? And you're going to try to optimize each part of that, okay, as much as you can. And then when you do that, you're doing your best to keep things in balance, right? But it can be overwhelming to think about trying to balance everything. But think of it as focusing on each individual part and doing your best with that one. And then you just know that you've done your best. Okay. So you have to find important things to talk about to your doctor, to talk to your doctor about. So the first thing is that some of these might be common sense, but you need to hear them, right? So general health screening. Are you smoking? That's not the best idea, right? I think we all know that, but some women come into my clinic and they've been smoking. They've been reducing, they've been lowering, but they're still smoking, right? So smoking's got to go. Alcohol. 1 or 2 glasses of wine or maybe beer a week is unlikely to cause any major problems. But if you're doing like 5 a week or higher, that most likely that number is associated with lower egg quality or hard time trying to get pregnant. So definitely, it doesn't say contribute maybe to PCOS except for those extra calories, but definitely something to try to reduce just in general, right? Because we want to take care of everything that we can. We'll talk a little bit more about weight a little bit while from now, but weight is important, right? And I know it's super hard with those with polycystic ovary syndrome, or can be. High cholesterol, high blood pressure, okay? These are things that are also associated with those with polycystic ovary syndrome. So having that checked is going to be a good idea as well. You'll get a blood pressure check, right? You'll have your weight checked, right? But maybe even getting screened for high cholesterol. Insulin resistance, diabetes, pre-diabetes, okay, insulin resistance. Those are things that I'll talk about in more detail as well, but very important. Exercise level. You've got to keep up the exercise, okay, especially those with PCOS. It's just that the metabolism in general is going to probably be a bit lower. But if you're specifically talking about fertility, right? If you're going through fertility, exercise just helps your mood, and it helps the egg quality, it helps carrying, it helps everything, okay? And it helps your sleep. I mean, it seems we all know this, but maybe if you're not, or you have a goal that you want to attain, you're not able to obtain it, then I think that using this form and this PCOS and the goal for fertility as another kick, right? It's a good thing. And I'll talk a little bit as well about sexual and mental health, but those are also super important because they have been difficulties with sexual or mental health have been reported widely and are common in a lot of people, but it's a little bit higher chance of having that if you have polycystic ovary syndrome. Okay, so and the thing is that you have to use with these things, you have to use a team approach, right? So if you happen to have more than one of these things in your life, it can be a lot. It can be a lot to try to change. Now, there are a lot of them associated with each other, right? But still, it's a lot, right? So you need to have a team, right? It's super important. So perhaps there is an REI. You work with an REI like myself, right? But you're going to work in conjunction maybe with a primary care physician, right? Don't leave them out. They want to see you and take care of you. Maybe they can help you with your cholesterol, and the other thing is, or a therapist, right? Or a counselor that can help relieve stress for you or your partner during these tough times. So really think, and I'm going to talk about some of these issues as well, but really think about it's a team, right? So you just want to get as many people around you that you can help. I know it can be overwhelming to make doctor's appointments, but once you get in and you have a plan and a project, that's a great place to be. Okay, just took some work to get in there, right? That hurdle, but you can get over hurdles. So let's talk about some of those things specifically, right? So sugar, prediabetes, insulin resistance. Remember that women with PCOS are 5 times more likely to have diabetes issues, right? If they're Asian, okay? 4 times if you're from the Americas, and 3 times if you're European. So it's something to definitely keep track of, right? So either a sugar oral glucose tolerance test, OGTT is the official term, but that's the sugar drink that maybe you think of when people get pregnant they take. That's something that they also do to help diagnose diabetes. Or a fasting plasma sugar, basically just a fasting sugar test, or hemoglobin A1C, which is like a 3 hour test that shows sort of like a 3 month average of your sugar. So it's a nice, because in case there's like some ups and downs that are sort of temporary, this gives you a nice 3 month average and a way to track the interventions that you're doing, like weight loss or eating better. So at least one of those should be done to assess the glycemic status. And really, the 2 hour sugar test, drink test, is the one that is most highly recommended. Okay, so if you come in and see your doctor and with the diagnosis of PCOS, some sort of glucose assessment is going to be super important, because we need to talk about insulin resistance to see if you have it, because there's interventions that we can do. And it's also good to know for the long term. Now, the one other one is weight. So remember, I believe that it is important to focus on specific aspects at a time, right? So weight. So if weight is an issue, then set yourself a goal. It's simple. You think about it. It's hard. Not a crazy goal, but one that is obtainable. That has always been shown to be the best goal to set. So do the best for yourself. So aim for a 5 to 10% weight loss goal over maybe about 3 months. Maybe they'll say 3 to 6 months as well. But we're also talking about fertility, and a lot of women, losing weight safely is something that you can do fairly easily. Okay, but we know it takes a team, right? So I'm like, oh, lose weight, right? Well, maybe that helps you. Maybe you're like, okay, I got it. I know the plan. I've done this before. But exercise, right? That's the first start, right? So that means start with a gym, all right? Or a workout program, okay? Get a trainer, or sign up for classes with a friend or a partner, right? Consider an app. And when those things stop working, and they will stop working, change it up, okay? Because that's what happens. We're human. We get bored, okay? It's okay. It happens. But you can't lose track of what you're trying to do. So what I want you to do, okay, is to, when it comes to weight loss, is get your team. You need your team, okay? When we talk about food, right, that's the other next part about weight loss. So see a nutritionist. Pick a common sense program, not one that denies you a specific part, like a no carb diet. No, go light on the carbs. Yeah, common sense stuff, right? But pick a program, pick a structure to it, right? There are resources. But also nutritionists, right? I think we don't necessarily think about that too much. And we feel like, oh, I got all the information online. I kind of know what's healthy, right? Yeah, sure. But 2 or 3 sessions with nutritionists can give you the tools that you need to organize yourself. We all need help organizing, right? So that's why that shows on Netflix are so popular, right? How to organize your life, right? So use apps, okay, to help you stay on track. There's a lot of good apps out there. Some of our RSC websites have some good ones as well. And through your insurance and through your primary care doctor, there'll be some, you'll be able to sort of steer yourself into some good areas as well, right? Again, do this with your partner or a friend, right? Find someone that you can be held accountable with, right? But also someone that can forgive you if we, and maybe this is something where you do it like 5 days a week, you're good. And, a couple times a week that you're okay. Maybe you're not good, but you're not bad, right? But that you're okay. Give yourself that leeway, right? Let yourself just kind of breathe and just kind of go with it. And the last part that comes with weight, so exercise, food, and then the last one is behavior goals. And this is a really hard part, right? Because this affects all aspects of your life. And so in addition to kicking yourself into gear with your team, right, your healthcare team, consider a therapist here as well. So if you have a goal that you want and you have a hard time achieving it, you got to find teammates, right? You need help, right? So not a lot of people think of a therapist when they think of losing weight, but we will all likely acknowledge that most of this is mental, right? And our actions. And so don't ignore it. Cognitive behavioral interventions are strong, okay? So don't sleep on it. Another part that's super important is mental health. Anxiety, depression, okay? These are all higher in those coming to a fertility clinic. It's also higher in those with polycystic ovary syndrome. So it's important to recognize that. If you had diabetes, would you focus on your health habits and take medicine? You would, right? So if you have anxiety or depression or think you might, you need to focus on your mental habits as well and see a therapist. Those can be helpful. They can be helpful. Then you can actually start to feel better. And better's better, right? So an important thing to also remember is that these feelings are very real and can be very strong. They can also be fairly situational. Patients come into my clinic, what's the situation? They're having trouble having a child, right? And that puts a lot of extra strain and stress. And so having someone on your team, another teammate, a therapist, right, teaching you slightly better just behavioral techniques or coping mechanisms or tricks or things like that, or ways to approach certain situations can be very strong tools for you. Okay. And the other thing that I say about the mental health and fertility, I always say this, is that don't wait too long trying to do this naturally. And I know that sounds like, oh yeah, the doctor who, I would come in to see thinks I shouldn't be trying on my own too long, right? But you'll burn yourself out. I have patients who come to me, maybe they don't ovulate regularly. They've done about 3 months of trying because there's a period like once, every 2 months or so. And after 3 months, like, oh, that's it. Like something's off. Let's go see a doctor, right? Those patients tend to come into my clinic more in control, more, I don't want to say themselves, but that they haven't had a lot of extra, they've had some. I mean, coming to my clinic is definitely stress, but not as much as I've seen the patients when I've been trying for a year or two, and I've been trying to balance my hormones out, or sort of like taking metformin forever and going to acupuncture. Metformin, acupuncture, good things to do. Not saying they're not, but they may not. They're, for a lot of people, not going to solve the problem, right? You might need pharmacological help, right, from a doctor. Okay, so you'll burn out if you wait too long, and because also, I have a medicine that helps women ovulate about 85% of the time. And I have tons of other awesome tricks up my sleeves, right, for the remainings of those who don't, right? Again, remember, someone comes with PCOS and I'm excited, that holds, right? So coming to me is not the end of the line. For a lot of women, it's actually the very beginning. So don't wait too long to actually start, okay? Or come and see a doctor, learn more, and then you learn, you're like, oh no, I'm fine, I'm gonna keep trying for another 6 months. Fine, great, but now you know, right? But the thing is, when you come into my door, the roller coaster doesn't stop at my door. It keeps going, and maybe keeps going for a while. Some women, this does take a little while. Not a lot of women, but some women, right? So don't be burned out by the time you actually start maybe doing some effective and good treatment. Okay, so those are the things that we talk about, right? We talk about also, so the diet, nutrition. I kind of like skimmed over some of the things about nutrition, right? Just as the concept of it. When you go to your doctor, there's going to be lots of things that you can take that might be potentially helpful, right? So every woman that comes into my clinic, I'm like, prenatal vitamins, okay? I say vitamin D. I'm going to say fish oil or omega-3. And then CoQ10, CoQ10 is a good treatment. It helps egg quality. A 30-year-old probably doesn't really have that much of a problem with egg quality, isn't supposed to. Taking that, though, can help and definitely doesn't hurt, okay? Men, by the way, we're on this topic, right? There's usually partners in the situation. Not always, but usually. Men, vitamin C, 1,000 milligrams a day, as well as fish oil, okay? About 500 to 1,000 milligrams a day of omega-3 or fish oils I recommend for men and women, okay? And so, but when it comes to, this is the PC, I'm not giving very more specifics than that because you have to know what's going on. Do you have insulin resistance, right? Is maybe inositol or metformin the right medication for you, right? Is it, it's hard to say all of the medicines that are out there and supplements and hormones and, herb blends that are out there but really coming in to see a doctor and then, or a healthcare professional and really getting a nice good summary of those things, but that's more tailored to you, okay? Food, remember specifically food. I didn't say go for a PCOS diet. I don't really know what that is. Okay. But the common sense things are like a Mediterranean diet, like lower carb, good fat, right? Nuts, vegetables, fruits, like things like that. Okay. So in general, though, when it comes to PCOS, lower carb is not no carb, but lower carb is going to be probably the general way to go. Okay. Now, When we talk about what, again, what to expect when you want to be expecting, right? So a lot of women are going to need help ovulating in polycystic ovary syndrome, right? Or maybe you do ovulate, but maybe it's every 40 days. And so medicines can either help women who ovulate irregularly or far apart, can help that speed up and be a bit more on track, like a typical sort of 28-day cycle. Or women who don't ovulate at all, we can help you ovulate. So there's two medicines, there's two pills out there that most women with PCOS will start with. So the one that is most recommended is called letrozole. That's the generic term, but the brand name is Femara. And there's a couple other names out there, but letrozole or Femara are the ones you probably see online and in most doctors' offices. That is a pill that you take one or two of them, typically two of them a day for 5 days at the beginning of your cycle. If you don't cycle, just requires a blood work, maybe an ultrasound in the beginning to make sure everything is okay, and then you start taking the medicines. You take these pills for 5 days. Then typically about like 5 days later or so, you come into the office for an ultrasound. And with that ultrasound, we're going to go look at those follicles again to see, hey, do I have a larger follicle growing? Because that larger follicle is going to be an egg that's getting ready to ovulate. Now, before we started all of this, we would have done some of the basic workups, right? So not only the polycystic ovary syndrome labs, but make sure you're not anemic. Check your blood count, right? Make sure you're immune to chickenpox, right? Because you might want to get immunization prior to getting pregnant. To get the things, the prenatal labs you get when you're pregnant, get them now before so you don't have a surprise, okay? And for those with male partners, we'll get a semen analysis, okay? And those are the kind of the basic workups of that. Checking to see if the fallopian tubes are open is recommended to be a conversation between the patient and the doctor, each individual. It's not a recommendation to do or not do it initially. If there's been a couple treatment cycles and no dice, then maybe checking to keep in the back of your mind, but maybe not do it right away, okay? Because the chances of the fallopian tubes being open with women with PCOS normal semen analysis, super high, okay? So like 99 plus, so but you don't forget that you didn't test it. Maybe later on you try it. So anyways, we have the ultrasound done, right? We've already done the semen analysis. So if that's normal, and we're kind of pretty sure that woman's not ovulating regularly at all, then we say, okay, give you instructions for timed intercourse, okay? And a lot of times, people will take a small little pre-filled injection. We teach you how to do it, or any clinic will teach you how to do it, and there's videos online. I mean, I know it's like, oh, just inject yourself, but it's really not that hard. I know it's scary, but it's pretty easy to do. Pre-filled, just clean, pinch, poke, and then push, and then that's it. Trigger shot. It triggers you. It triggers the ovulation. It ensures that a woman will ovulate. And when a woman gives herself that injection, she will ovulate just about 36 to 37 hours later after that injection. So then you know when to time intercourse. Usually you give yourself, say, an injection, say, night. Typically how it works is maybe injection like at nighttime, by the time you get the labs back and the information. And then that means that you would be ovulating 2 mornings later, 36 hours later, okay? Sometimes my patients, I'll have them do the injection in the morning, like just the next day, because that way that they're having, they're ovulating like the following 36 hours later, which is nighttime, and just easier for intercourse, of course. Instructions that have frequent intercourse after that injection. You can also ovulate on your own. The body, even though it has struggling ovulating with polycystic ovary, once you've kicked it into gear with that medicine, then your ovary will almost always take over. But we do tend to do the trigger shot and recommend it because I think it just helps people with the timing of ovulation, just kind of ensures they ovulate correctly, because every once in a while they won't. But and then intercourse, and then we try that. Now, the way letrozole works is that it essentially makes the ovary a little bit more sensitive to the follicle stimulating hormone that your brain normally makes. It makes every month. It rises every month, but your ovary is hard of hearing. Okay. Insulin resistance, higher testosterone levels, those also contribute to that sort of FSH resistance in a way, that inertia that the ovary has. So knocking those down, right, can be super helpful. And letrozole also probably increases maybe the signal from the brain as well. Another medicine out there is called Clomid, Okay, CLOMID. And that is one that is the most well known. It's been used for the longest time. Okay. But we know from a randomized control trial done a while ago at this point now, maybe 8 years ago plus, that letrozole in head to head is better than Clomid for pregnancy outcomes in those with PCOS, polycystic ovary syndrome. Clomid's probably better for those with unexplained, women who ovulate regularly, right? But for PCOS, letrozole or Femara is the way to go. Using Clomid's not wrong. It's not bad, okay? But letrozole is best. So, if the semen analysis comes back as low, or maybe you have been ovulating, but it's actually made it every 45 days, but it's been a year, like, well, sometimes then we'll add an intrauterine insemination, where a man would give a sample the day of the ovulation. The sperm would be cleaned, concentrated, and the best sperm that the man makes would be placed as close as possible to those eggs with a small catheter, a quick 5-minute procedure done in the office with a speculum. Okay, to place that sperm as close as possible to those eggs and give them good luck. Okay, so that's the typical first line treatment. Okay, typically letrozole and timed intercourse. Okay, with monitoring to ensure that's a safe ovulation. The second line, because about 15% of women, maybe 20-15%, will not respond to the medicines. That's when we start talking about other medications that we can help that might aid the letrozole or the Clomid. Specifically, a big one is called metformin. Okay. Now, some women get metformin first, right, to see if they will be ovulating on their own. Because remember, metformin is a drug that reduces insulin resistance. Okay. And if you knock that peg out from PCOS, maybe that's enough for the ovary to start ovulating. Doesn't work that reliably, but it does work for a percentage of the patients. But typically, we're not just doing metformin and then waiting like 6 months for the letrozole, then to start the letrozole or Clomid if I'm treating that patient. But we're maybe starting them in conjunction. Or if someone doesn't respond to Clomid, you can do a couple different things. So to reduce insulin resistance, what you can do is that you can start metformin, okay, pharmacological grade medicine. It's used for diabetes. You titrate up, but ideally you're taking about twice a day, maybe even 3 times a day, depends upon the formulation. It's hard on the stomach and the GI system initially, but it is self-limited, it'll go away. And then eventually what you'll do is that you'll end up with hopefully lower insulin resistance, and your body may respond to the letrozole better. Maybe stopping treatment for a while and focusing on weight loss, another 10-15%. Okay, reducing weight loss reduces fat tissue, reduces insulin resistance. Okay, that's why we do that. And there's other things that you can do. There's dexamethasone that's maybe sometimes works, depends upon the issue, which is like a low-grade steroid that a lot of women might take here and there for other reasons too. There's a couple other things that people don't tend to do too much. Even birth control pills for about 2-3 months, because then when the ovary starts to wake back up, the testosterone level takes a while to kind of ramp back up. And some women will actually start to ovulate a couple of times on their own for a couple of months before the ovary goes back to where it was. That's a lot to ask a lot of women, but some women will do that. Okay. That's the first level, is the pills, maybe doing some adjuvant medicines, the official term for that, in addition to the Clomid, or other lifestyle interventions may be warranted. If that doesn't work, the second line would be injections. Do you remember the follicle stimulating hormone that we were trying to trick in your brain for turbo boosting or to making your ovary more sensitive to? We can just teach you how to give yourself stronger doses of the medicine. The signal from the brain, just yell at the ovaries to turn over. That, I'm not going to discuss that in too much detail here, but that is something where it can lead to a lot of twins or higher order of multiples. Not a lot of clinics are doing that. Sometimes every once in a while we'll do the combination. I'll do pills with the injections and just try to find that good middle ground. But monitoring of ultrasounds is key. 1 or 2 larger follicles, the 2 follicle maybe gives you like a 5-6% chance, 6-8% chance maybe of twins, right? Well, but if I have 3 follicles, then the chance of twins starts to go up a lot. And so for my patients, typically, not everyone does this. There's no hard rule here. I'm looking for 1 or 2 follicles, and if it's more than that, I'm like, stop, cut, no, separate beds. No one try to get pregnant right now, or no IUI if it's maybe with a donor sperm or something. Let's try again next month and learn from this cycle. In PCOS, that first cycle or two, you're learning about how a body's going to react. Not everyone fits the same mold, of course, right? So it's important to find that first. There's another section which is a legitimate, which might seem kind of weird, but actually surgery, laparoscopic surgery it's called ovarian drilling, where a surgeon will actually kind of damage very small, controlled pieces of the ovary on the surface. Doesn't hurt the ovary, doesn't hurt the blood supply. It hurts the ovary, I suppose, right? But it doesn't hurt the overall function. But what it does is that it essentially reduces some of the burden, that the extra ovarian tissue is probably what's making too much of that testosterone or androgen. So by sort of shutting part of it down permanently, it lowers that level, and a lot of women will then maybe even ovulate. A lot of them will actually ovulate on their own. And those who didn't respond to the medicine, most of them will respond then to the medicine. It's not one that's widely done, but it's actually one of the older treatments that was available. The original people that sort of coined it were also doing it as well at the time. Not a lot of people do it, but it's definitely a possibility, okay? And then the last part is IVF, in vitro fertilization. The key, I just want to let you know, is that nothing in fertility is guaranteed. I can never guarantee you that this is going to be successful, right? But it's as good as it's going to get if a patient who needs to do IVF comes in with polycystic ovary. That pool I told you about, that one that was sort of dragging you down and not letting you ovulate, that pool is your secret weapon. Because in IVF, what we do is we give large doses of the medicine safely, but larger doses. Remember before when you ovulated, more than 2 and no? No, here we want all of them, okay, or as a lot of them. That pool, I can only stimulate the follicles that are in the ovarian pool, the ovarian reserve, okay? And that's dependent upon you. And when polycystic ovary their pond is stocked. So giving the larger doses of medicine will allow multiple eggs to grow at the same time, or develop, I should say, mature inside those follicles. And then in IVF, we don't let you ovulate dangerously, okay? We retrieve those eggs and remove them, okay? Put them together with the sperm in the lab. 5 days later, we check to see that single egg and single sperm, those 2 cells become a 120 cell blastocyst, which is today considered a mature embryo. And ones we're typically in a situation, we're freezing. And so we're not doing a fresh transfer of an embryo, because most women with PCOS will have a strong response to the medicine, because you can't hold a good ovary down. So once you cross this activate threshold, the ovary just is and that's a great thing. We want to keep all of our patients really safe. So doing a fresh transfer can lead to complications called ovarian hyperstimulation syndrome, which can be dangerous for the mom and the baby, he or she herself. Okay, so we definitely usually embryos are being frozen in that. Okay, so polycystic ovary syndrome is a multivariate animal, right? It's just multi-headed animal. It's fertility, right? It's parts in weight, it's parts in diabetes or sugar, right? It's in mental health and sexual health as well, right? And all of those are super important. So the big takeaways here is that if you have PCOS, for the most part, for a lot of women, it's a hurdle, but it's one that you can get over. But unfortunately, the road might lead through me, and that's no one really wants to go see someone with a white coat, but but don't wait too long for that, right? Maybe don't see a doctor, maybe or maybe your primary care, maybe don't see a fertility doctor, right? But see someone, get your team together, right? So maybe a therapist or a counselor, nutritionists, apps, friends, right? But don't wait too long. Don't get burnt out, okay? Trying to do this on your own. That's what we're here for, right? We've done, again, I've been helping with PCOS for 10 plus years, right? My colleagues have been, doing it for about as long or longer. And so it's just something to, it's tough. It really is, okay? But it is something that we can help you with, and any OBGYN or fertility doctor can help you with, okay? So thank you very much for listening to this talk. I'm also going to be talking about recurrent pregnancy loss. I have no idea the schedule, so either before this or after this or somewhere on the website as well. So you can want to check that out if you'd like. But contact your doctor, okay? And then the other thing is that I want to end with this, knowledge is power, right? So there are PCOS guidelines for physicians that came out 2018 or so, big international guidelines that I have used as a good guidework or framework for this talk, okay? But the specific website doesn't help if I set it out. But if you Google human reproduction, PCOS guidelines, human reproduction is the journal that the guidelines came out in, okay? So human reproduction, PCOS guidelines, Google that, you'll see it pop up and gives you just a good way to look at the information, the things that you have to deal with discreetly, concretely, basically. And I think that's the best way to go ahead, okay? So I hope you enjoyed my talk. Thanks for listening. Again, my name is Michael Homer, working at the Reproductive Science Center in the Bay Area, coming at you from San Jose. All right, guys, take care. Bye.